The broadcast is now starting. All attendees are in listen-only mode.
Hello there. I am Carrie Sullivan. I'm the Director of Marketing Communications here at TechScan, and I'm going to start by thanking everyone for joining us tonight. We really appreciate you sharing our time with us. We have a great presentation today. Our speakers are going to share more about their process using digital tools as both diagnostic and also as a key piece to the overall patient education process. Our speakers are likely familiar names. Dr. Mark Montgomery actively teaches with the Hornberg Group and has been using the T-scan for close to 20 years, lecturing and teaching for many of those. Dr. Montgomery has a real passion for transitioning dental practices from single-tooth dentistry to comprehensive oral care. Dee Dee Reid has spent many years as both a treatment coordinator and executive leadership coach. She is a master communicator focused on building trust with patient through effective communication. This has led her to teaching teams to master this skill. I encourage everyone to take advantage of the opportunity to hear from both Dr. Montgomery and Dee Dee directly, so we will have a live Q&A at the end of this session. Please send all questions through the chat panel and GoToWebinar on the right side of your screen. We will do our best to answer all questions at the end of the session. If we do not get to your questions, rest assured TechScan will certainly follow up with you directly after the session within the next few days. With that, I will pass the reins over to Dr. Montgomery and Dee Dee.
Hello, everyone. My name is Mark Montgomery, and this is Dee Dee Reid with me. Hello, Dee Dee. How are you doing tonight?
Great. Super great.
So I'm really excited to be with you all here tonight. I just had a great conversation with Dee Dee just before when we were signing on, and she mentioned to me that she had just gotten her brand new iPhone, and it's sitting in a box on her desk, and she hasn't even opened it up yet. So I think that there's something about new technology that sometimes is a little bit scary because we're not sure what's going to happen when we first jump in on it. And there's something about new technology that is exciting, and we know that it's going to be able to do incredible new things. And so Dee Dee, I'm wondering what you expect this new iPhone to do for you that you couldn't do before.
Well, my current one is pretty slow, so that in itself will. I hope that it will be faster. But having somebody help me put it together and make sure that I download and upload all the things properly, I think the iPhone is just going to be my magic robot, right?
It is.
That's my goal.
Well, yeah. Hopefully at least the battery will last a little bit longer than the old one did. So, it's so incredible to me that when we first get started with new technology, whether it's a T-scan or an iPhone or whatever it is, that it takes a while for us to really figure out how we're going to use it. And when I first started with T-scan, I think I was thinking that it was just going to be electronic articulating paper. And then the next thing I realized was, holy mackerel, this is a great way to show other dentists how to think about occlusion in a completely different way. But then, as time went on, I got talking to Dee Dee, and she said, really, you don't have a clue about how to use your T-scan correctly. And I thought, what are you talking about? And so she took me down this entire rabbit hole of how to disrupt my diagnostic process, and that's what we want to talk to you about tonight. I know that we have some specific objectives to you, and Dee Dee, why don't you tell us a little bit about what you'd like to share with our group here tonight?
Well, first, I know that you and I've had this discussion many times that I would not work in a practice that didn't have a T-scan. And that's actually, with me moving to California, that was one of my first requests, that in order for me to do my job well and to enroll patients in the most comprehensive, best options for them for treatment, that T-scan is one of my main tools that I use, both from a visual standpoint and an education standpoint, so that patients get the big picture. They're not going to understand all of the technical details as we would as professionals, but it's definitely that visual representation of a dynamic chewing system that, and I like to talk about it being a, you don't have just one tooth doing its own thing. You've got a whole chewing system that works in harmony, and T-scan is able to bring this to life. So, go ahead.
So tonight we want to really kind of demonstrate how we're going to disrupt the pattern of screening and examining our patients so that they open up to more of that systematic, comprehensive kind of care. And of course, I have to talk a little bit about occlusion in a little bit different way. And we're going to share a little bit about how we do that and what language we use to do that. And then, of course, how does this system of evaluating forces, how does that let the patient connect what's going on in their own mouth with what we would like them to experience? So I guess first,
Mark, I also want to talk about what the definition of disruptive is. Because when I first was working with that term, it was like, well, that's like maybe someone being a troublemaker, but that's definitely not the definition that we're using here. I mean, I'm a troublemaker on my own. I have enough of that going on, but disruptive in its pure form is innovative or groundbreaking. And I feel like it's really something that may be outside of our comfort zone at times. And so that's when we're talking disruptive, that's our meaning.
Well, so why do we have to disrupt anything? I mean, aren't patients just readily coming in and getting comprehensive care and all of that? I mean, the patients that show up in our practices today who are doing comprehensive care, the stories that they're hearing about where patients have been up until now is that they've been somewhere else and they've been treated like a number, not like a person.
Right. And they come and tell me that, that other practice or that other doctor wanted to do this to me. It wasn't something that they wanted for themselves. And what I hear all the time is that they haven't been listened to. So
one of the things that is really valuable for me is in a disruptive way is to create a window into how big our profession really is. What are all the things that we're thinking about in dentistry that the patient really has no idea about? I mean, they think they need their teeth cleaned and a cavity filled or something like that. And yet we're so wrapped up in the whole physiology of the patient, in preventive care, in metabolic disease, in diabetes and blood pressure and airway issues and TMD. I mean, there's so many things.
Posture, growth, and development. I mean, besides all the small possibilities and implant placements and stuff.
Yeah. So I think if we continue to do things the same way, then we're going to get the same results. And if we're getting the results we want, then certainly we shouldn't change anything. But if we need to think about moving patients into a more comprehensive mindset, wow, my T-scan is my number one, my number two tool. I mean, I got to have other diagnostic tools as well, but T-scan is critical to be able to look at the big picture for our patients and see things more comprehensively.
I totally agree. So let's go to our next slide and talk about that. So this particular patient came in and she had a problem with one tooth, and I wanted us to take care of one tooth. And I'm like, well, which one would that be? Because I see several that, have pathology.
Or the chipped one, or the broken one, the recurrent decay
Or
underneath.
the sorta other brown one, and the sorta dark gray one.
Yeah.
Yeah.
Well,
So she came in for tooth number 9 because it was dark.
yeah. But as we started having the conversation with her with a comprehensive approach, with a disruptive kind of approach, it allowed us to get her to a place where she realized that the things that she really wanted were way bigger than just that dark tooth. The reason she didn't like the dark tooth was it affected her smile. And her smile was a problem because of
and that her grandchild.
And her grandchild.
Yeah, and her grandchild pointed out that, Mimi, your teeth are really dark yellow. Why is that one tooth yellow?
Right. And so with a different approach, then we're able to step in and create a way forward for her. Not that this is perfect dentistry, but this was a way forward for her to have something more than she probably even imagined when she first came in. So I'm really thrilled with the idea that by taking a more comprehensive approach, that we can move beyond just the signs and symptoms of disease that we see all the time, every day.
Mm-hmm. So I know that Mark, you and I call that symptom chasing, and that is what the medical world has been doing for a lot of years. And I know that you and I take pride in really looking at a bigger wellness approach and not just band-aiding the signs or symptoms. So that we've got to look at it from a really comprehensive way.
So what are the things that get patients locked into that symptom chasing?
Well, there's the way we've always done our exams typically is there's a problem, here's an answer. There's a problem, here's an answer. Versus really digging in with the patient on big picture on, what their expectations are of us and of their overall health, so that they can, have the health that they want, or that they're not redoing dentistry time and time again. I mean, that happens all the time. It's like, how many times was this crown that's cracked and broken? How many times has this patient had this redone? And then why was the crown done in the first place?
And why is the tissue around the margins completely inflamed? I mean, this whole situation here with this one tooth, which is actually, it was a crown first, and then the tooth in front of it was lost. And if we don't take the time to just say, why did this tooth break? Or why did you lose that other tooth? And why did it break again? And if we don't have a way of thinking through that, where we're not telling them, but we're letting them describe for themselves what's going on with their condition. I mean, too often we see patients like this come in, and the first thing I want to know is, well, as a dentist, I go, oh my gosh, how did they get these 6 ceramic units on these front 6 teeth, and they didn't build enough retention for them in there, and did they really need an endo, and why did the tooth come all the way off, and what's going on around the margin of the other tooth? And the first thing I think is, oh man, that dentist really, what's going on with that dentist? And then I have to stop and look at the whole mouth and say, wait a minute, this whole mouth is collapsing. Everything in here is overloaded. And if I don't take the time to have a conversation about where the patient is and how they got there, then all I'm going to be doing is taking out 2 broken roots and putting in 2 implants, and next thing I know, something else is going to come apart. And that's not my heart for this patient. So the question is this time to place blame for what we did wrong, whether it's me doing it or somebody else? Or is this time for us to say, really, what were the expectations of the patients in the first place? Why would they invest in these ceramics on their front teeth and then have it come apart and be disappointed? What was going on in their heart about this one process? And that's what leads us into situations like this, where this patient comes in, and obviously this patient was interested in cosmetic dentistry, right, Dee Dee?
No.
What?
I mean, not really. He was fine with the way his teeth looked. He just wanted to fill in that space because
But he had those
the rest of them were
PFMs,
fine.
he had those 4 beautiful PFMs done on there to fix his smile one time. He must be interested in cosmetics.
No, he did that because those teeth had broken down, and that they're fine because he's married. He's not on the single market. I hear that from guys all the time. It's like, I'm not interested in cosmetics. He wants health and function is what when he came in, that was his goal.
But then when he
he just didn't want to end up with another tooth in the front.
But then when he does lose number 7, and the patient walks in and they've already seen the surgeon who's taken out number 7 and put in an implant, and they want me to put a crown on number 7, I have to stop and say, wait a minute, how am I going to get one crown in this mouth and have this be successful in this patient's life? So traditionally, as a dentist, we were trained to examine first, talk most, and then let the patient know what our opinion was. And that was traditionally how we were trained. It was to do this comprehensive exam and then tell the patient all the things that are wrong. And for me, that never really worked because, frankly, they weren't my teeth.
Right. I mean, like, whose life is this anyway? We are here to be in service to our patients. And if we don't ask the questions on what's most important to them, we've missed the mark.
Yeah.
And that's when I get the most new patients from other practices, is because they say, I went in there and I wanted to talk about this one thing and no one really heard me.
So you use photographs a lot at the beginning, and I know that's really where you start your disruptive conversation. Tell us a little bit about what photographs of the patient's teeth do for your relationship with the patient.
Well, it has the patient see what we see. And that's what I tell them. When my doctor walks in with his loupes and he's examining, the digital photos are showing exactly how the doctor would see the patient. And I want the patient to be able to see themselves and make great decisions for themselves, from what we can see. Because if they can't see it, it doesn't exist. It's just they would have to believe us that this is how it is. It also gives me perspective in when we pull up a retracted, slightly open photo, and they're like, oh my gosh, what is this? And what is that? And, oh, I don't like that. And the things that they point out to me, I can look at that previous photo and I could have a lot of conversation. But if I don't know what's important to the patient, I want to focus in on the things that they tell me are important, and then I will ask, do you mind if I share with you what I'm seeing?
So what you're saying, so what I hear you saying is that it's not so much that you're educating them as it is that you're revealing themselves to themselves. And that somehow,
absolutely.
and that
it's like
creates,
putting a mirror.
And that somehow creates a connection point for you?
It does, because it opens up that I'm interested in their opinion, in their desires, in their wants for the future, and maybe even uncovering their disappointment that has happened in the past. And the emotional side of that is critical in creating trust. We hear that all the time. We've got to create trust in order for patients to move forward. Well, if we're not listening and we're not showing them, it's very hard to do that. I mean, 83% of people are visual learners. So this is one of my best tools, is using photography as well as our T-scan.
So I also hear you talking about how you ask a lot of questions. And, I think there's an old Walt Whitman quote that says that curiosity is the opposite of judgment. And, these patients come in and a lot of times they have a lot of judgment about themselves. and they're afraid of judgment from their hygienist or from their dentist. And that judgment of themselves, the guilt that they haven't taken care of this in the past, or that that their parents never took care of this when they were young, the guilt and the money expense and things that are obstacles that hold them back, they really don't. They're afraid of dealing with that because they're going to feel judgment. And so I hear you saying that you use questions to get past that judgment.
I do, and I let them know that in our office, it's a judgment-free zone, that we are here to be in service and to hold them up, so that, I know that people are their own worst critics, because I experience that on a frequent basis. And so it's connecting on that there's no reason to be embarrassed, and that, we are here to hold their hand and walk with them, on a path forward that gets them to a point of being as healthy as they want to be. And it's not my job to judge where that health line is. Some people want to fix things when they hurt or break. Some people want to be super proactive, and then all of the spaces in between. So that's not my decision to make. It's the patient's, and I let them know that they're in the driver's seat on that we will serve them at the highest level that they prefer. But it's my job to ask great questions so that we can get to that point. And then also being able to illuminate possibilities that they probably didn't know before they walked in the practice, so that, we can deliver the best that dentistry has to offer. And that's my hope for patients all over the country, that this is, that we can deliver the best that dentistry has to offer, and that patients can choose that for themselves.
So if we have a patient, if we have a patient like this who comes walking into our practice, and when you start thinking about how you're going to open this patient up to what's been going on in the past, and get them to own their own disease, or own their own process, or own their own condition, like, no kidding, like, own it, so that they can feel like that they are understanding their reality, then what kind of technology is going to help expose that for them? How are they going to really be able to explore their condition in that way?
Well, we definitely want to look at all of the diagnostic records that we would be taking. And I do this pretty early in the relationship. I go ahead and get a panoramic x-ray, so I can see the joints and the sinuses and the jawbone and all of that, just to see if, are we going to have any big surprises. And then we're able to do some digital photography, and then take my T-scan. And, there's other times where we take a CBCT or an FMX. And then recently we've been doing digital optical scans, so that they can, see their mouth in 3D, which is kind of fun as well. And I know, Mark, you use the joint vibration analysis on a regular basis with patients.
Right. I think that we have such great tools today, and a lot of us have some of these and not all of them. Some of us have all of them, and yet we've pigeonholed them into a specific place in our process. And I think that for me, the idea that I can take all of these digital records before I do my exam really has freed me up from having to be the bearer of bad news. That by them being able to see, number one, that we're thorough, number two, that we are technologically advanced, and that we do belong in the 21st century, and then use those digital diagnostic records in a way that disrupts our relationship right from the beginning, and puts the patient in the driver's seat right from the beginning, so that they don't have to wait and be afraid of what they're going to hear in their exam. They can be in the driver's seat from the very beginning. somewhere along the way, I learned that anything that I diagnose after I do my exam, I do my exam and then I tell them the diagnosis. That's just like me trying to sell them something or upsell them into something bigger or something like. They're always suspicious of that. But anything that they can discover before I do my exam really brings a level of trust and collaboration to the whole conversation.
Well, and it also brings curiosity from the patient because they are already seeing things and noticing things and then wondering about that. And that time of wonder, what I like to call their simmer time is, where they can kind of sit with, oh my gosh, I didn't know. I hear this all the time. When I bring my doctor in, they're like, all right, doc, I didn't know it was this bad. But boy, we've seen a lot of things in the photographs and the T-scan, prior to you even coming in the room. So
yeah, I think that it just seems kind of backwards for a lot of us to say that we're going to prescribe all of these digital scans before we even do our examination. But we know that it's so revealing of all of the things that might be underneath. And it does give us a chance to educate a little bit when they say, well, why are my arches all collapsing in and getting all crooked? And, I had braces when I was a kid, and do I need braces again? And, and we have a chance to talk about tongue function and myofunctional imbalances or airway issues where their tongue is plugging up their airway or whatever it might be, that when we have these photographs, that is like the first big aha moment for the patient in there. And then,
well, it's almost like forensic evidence that they can see before we get to the real, the comprehensive exam. So it's uncovering clues to there could be bigger issues going on.
Have you been watching those forensic files again? Is that what?
All the time, you know me.
So
that's my favorite pastime.
So what you're saying is a lot of our patients are just crime victims who need to be studied and figure out what's going on.
100%. I think I learned this a long time ago, that when we look at x-rays and photos, that I'm looking at crime scene diagnostics. So,
exactly. When I did dentistry in the prison, we just called it, veterinary dentistry because we had the hard data and we couldn't believe a thing that the patient told us. So we just had to go with the x-rays and the things that we could measure ourselves. So when we start taking T-scan on patients right off the bat, the patient's already seeing the pathology and the things that are coming apart and the things they love and they don't love and the things that they understand and don't understand, and why this tooth is black and why that one's brown and why this has a hole underneath this and why the tissue's all puffy in this other area. When the patient starts seeing these photographs, and then we start coupling that with the fact that the forces in the mouth that are applied to the teeth through the muscles, when we look at the muscle imbalance and the dental force imbalance on the T-scan, that we can really get a picture of chewing dysfunction. And I'll tell you, in all my years of teaching occlusion, my patients have always understood this much faster than most of the doctors who take the class. And they understand that the damage on their teeth comes from the fact that something is not working correctly, and that it's whether it's chewing or parafunction or dysfunction, but that when the forces are out of balance, that damage is going to occur. And so I think that it really gives us a chance for the patient to take another look at the whole arch, because the whole arch is a way of the patient to thinking about not just one tooth, like you said earlier.
Well, we talk about that. It's a chewing system in harmony, and it's not just one tooth doing its own job. Just like that previous photo that you showed where the crown was cracked and broken. It's like, well, how did that happen? And it's not just that one tooth that's probably the underlying cause and reason for this dysfunction. So,
Yeah. And when we can start, and then if we want to, we can even correlate muscle measurements with the force feedback of the teeth, and we can get an even bigger picture of this patient's whole condition. But right now, at the disruptive stage of our diagnosis, our goal is to really just take a T-scan, put the sensor in the mouth, and get a sense of where the forces are that are going on in their mouth. I'm not ready to equilibrate. I'm not ready to treatment plan. I just want to get a picture of what's going on. And the coolest thing now, the coolest thing now is that we can use completely different language for what we see. That that when we take a look at a scan, that we are going to see forces on the teeth in a dynamic way. As the patient occludes and comes together, we can see bite prematurities, we can see imbalances, we can see lateral excursions, we can look at all kinds of technical aspects of things. But you know, I'm never going to use those words anymore with the patient, especially not a brand new patient. But what I am going to do is I'm going to say, so what does that seem like to you that 40% of the force in your mouth is on the back, the very back tooth on the left, and that 30% of the force is on the very back tooth on the right? Can you see those towers of force? And I'll show them these the bar graphs that go shooting up in the air, and they're like, oh, that can't be good. And when they understand quickly that the force distribution in this mouth is just not going to be healthy for them long term, right? And you know, technically this could be complicated. This could be an open bite patient. It could be a TMJ patient. It could be an airway patient. It could be a growth and development patient. There are all kinds of things that could have generated this and all kinds of ways for us to think about approaching it. But the important thing at this stage is for the patient to own the fact that their chewing system's out of balance. And
we always talk about how we don't really talk in technical terms. It's like you see these tall bars here, these are towers of force, and all I want this diagram to show is for the patient to start being in wonder and curious about their own situation, because and then that helps when we're in our exam, because they are engaged in the exam process. So tell me how that correlates with my muscles. Maybe it's because they're a headache patient or TMD patient. But they've got to be able to see it.
So you would actually show them the towers of force, and if they weren't wondering about it yet, then you would wonder, right?
Absolutely.
So how?
Yes, I would, and that's what I would say is I wonder what caused it. Huh.
Yeah.
What would you do, Mark?
Yep, we see that all the time. Here's another example of a patient with huge towers of force in the posterior, and we see a huge left-right imbalance in here. You don't have to be a high-powered T-scan user to see the fact that it says 59.9% of the force is on the left and 40.1% of the force is on the right. It's like, and when the patient goes that, they go, oh, you know what? I've been working with my chiropractor to get my spine aligned, and you know, this can't be good. Shouldn't this be in balance just like my hips should be in balance? Or, I mean, it's amazing how quickly the patients pick up on the fact that the body should be in balance from right to left. And when they get that, it adds into their curiosity about, wow, you know, should we be looking at this when we're doing our exam? And of course, you know, it's like, yeah, definitely we should be, because this is going to be contributing to other things that are going on in your mouth. And when they can take that take that scan, that T-scan, and start to correlate the imbalance that you're seeing in the T-scan with the problems of damage and destruction and pathology in their mouth that shows up in their photos, it's like, wow. So when we disrupt this conversation and we start them off seeing their own situation without education, just as a discovery process, almost like the first part of the trial.
And from an objective example. It's like I just took these photos. These are your teeth, right? You know, it's not like I've changed anything on the photos, or it's not like I've changed anything on the T-scan, because they can see it going on the screen as they're biting on the sensor. So it's dynamic and it's in real time.
Yeah. And it's funny what patients will notice. Like some patients might notice the erosion on 6, 7, and 8, and then somebody else says, "What are all these bumps up here underneath my gums?" And it's like they can see the buttressing of the bone up there from all the years of too much force that have gone on. And when the patients start asking questions like that, we're so far down the road to helping them create an approach that's going to create an opportunity for their care. So
definitely,
I am so convinced that there is nothing better for my conversation with the patient than to have a scan. I can mark the teeth with carbon paper all day long and get out my intraoral camera and try to show them, pick the marks on the teeth. And number one, they can't get it. Number two, they usually can only look at 1 or 2 teeth at a time. And number three, all the research shows us that marks on the teeth don't tell us anything about the forces on the teeth or the timing of those forces. So,
right. And that's something I explained to them. This technology will let us know which tooth hit first, second, third, what the relative force is on every single tooth in the mouth, if it's balanced left to right, front to back in their chewing motion, and that it's not just taking a snapshot, it's taking a full movie of this dynamic chewing process.
Yeah, and then our education process kind of kicks in, and we start explaining to the patient that there are really, 4 main areas of pathology that we look at. I mean, the things that destroy teeth are acid, infection, and force. Those are the things that destroy the teeth. Where those forces come from might be from airway problems. They might be from general postural imbalance. It could be something developmental. It could be the fact that Montgomery put 2 crowns on him and he didn't get them dialed in. But these things, having the patient have a simple way of looking at what goes on with their mouth and saying, yeah, this is acid, force, and infection is what causes your teeth to come apart. And then we look at those pictures and the T-scan and say, oh yeah, so all these forces are really responsible for all this damage. How are we going to reverse that? And we have to take a look at the chewing system and what are all the things that are going on when we evaluate the distribution of forces. So as the teeth come together with the T-scan, we can see what happens early and we can see where things end up later. And the timing of what goes on in the dentition has been a subject of my extreme obsession for years, because the neurology of feedback loops between the periodontal ligament and the muscles of chewing and swallowing and tongue function are intricate and fascinating, and the whole trigeminal system is unbelievably effective and fascinating. But when we start talking to the patient about the fact that their issues in their mouth are directly related to these forces, then we can get to a place where we can have a conversation about whether or not it makes sense to them to change the way their chewing system functions. Does it make sense to them to bring this back into balance? Is there proprioception problems? Are there pain problems? Is it just an unbalanced system? And when we start looking at the overall picture of dysfunction with the patient, then we start to get the patient interested in more than just one tooth at a time, because they know, number one, that you can't fix this overall problem one tooth at a time any more than you can put Botox in your lower calf muscle and bring your back into balance again. You know, it takes a comprehensive approach for that.
And they also appreciate what also creates a stronger bond of trust is that we are looking for the underlying causes. We're not looking for the incident that had it happen. We're looking for what is the underlying root cause to their symptoms or their signs. And if we can get to that and then correct it from that foundational level, they're going to have a better long-term solution. And you know, I hear from patients all the time, yeah, can we do it once, do it right, and I never have to come back here except to have my teeth cleaned? I'm like, absolutely we can. But in order to do that, these are the things that we need to get to the bottom of and do some study on and diagnostic records for, so that, you know, my doctor can get to that root cause for you.
Yeah. You know, I think that one of the things that's been intriguing to me is how patients really don't accept our names for things, that they don't accept the fact that they're grinding their teeth or clenching. You know, they don't accept the names that we have for things. And so we've quit using nouns as much as we possibly can. And if you ever come hear me speak, you'll hear me talking about ing words. You know, these problems are not things that they have, but they're things that are going on, things that are happening. And that shift of shifting away from saying that you have wear to the fact that your teeth are wearing down,
or melting,
the enamel's melting away, that when they get into the ing words, they're much more likely to understand that there's an urgent concern here. So in the long and short of this is that now we can take our optical scans and correlate it with our T-scan. We can take our T-scans and our photographs at the beginning, and we can create the kind of conversation with a patient that discovers and uncovers what their values are. What's the patient's big picture? What are the things that we need to know? How can we correlate these problems with what's going on with their chewing system and their teeth coming apart? And this way of having a conversation, it allows us to develop an approach to care that, like Dee Dee said, gets at the heart of the issue, driven by the values and goals of the patient, not just some idea that we had that this is right or this is wrong or this is a good tooth and that's a bad tooth.
Or this is something they want to do to me. You know, it's they actually get that this is a condition that they have and a problem that they have that they want a solution for.
Yeah. So. And then, of course, certainly we are going to do an exam and all of that. But now we're going to base our examination on our screening. We're going to base it on the assessment that we've taken, because not every patient wants the same approach. If we already know the approach that we're going to take, it changes the way we do our exam a little bit. We still have to be thorough. We still have to look at all their health history and all of that. But if we know going in that this patient is not really interested in treating their periodontal disease because they have an immune system disorder and cancer, and they're tired of being sick and tired, and they're tired of fighting, and they would rather have implants and a reconstruction, or maybe something in the middle where maybe they want to have dentures, and maybe they're asking for dentures. And maybe that leads us into a different kind of conversation. But when we know the values of the patient, then our treatment plan is based on what the patient's results plan is. So
well, and it also affects how we language things. You know, I talk a lot about let's language it from what the patient has already told us in their language. So we may say decay, but the patient says cavity. I can't tell you, I've gone all the way through a case presentation, and we uncovered all this decay and issues with the patient. And then they said, well, doc, do I have any cavities? And I'm like, oh my God, we so did not listen. And so we changed that the very next patient, because it was like, what in the world? We've been sitting here talking for an hour, and you know, and then we still got that question. So it's super important that we listen to the language of the patient and actually repeat back to them after we've done our examination in their language, so that they understand.
And that gives us such a great opportunity to build education around what's the timing of how the teeth come together. Should they all come together at the same time, or should we have towers of force? Or should we have even contacts all the way around the mouth? Should something be early and something be late? I mean, we talk about things being simultaneous when you close together, but does anybody really have that? And how do we get as close as possible without becoming obsessive compulsive about this? And how can we put the balance of forces in the mouth right in the middle of the target zone on their T-scan and get an idea of, you know, hey, is 47-53 a pretty good balance or not? And which teeth, even if we are at 53-47, which teeth are early? Which ones come in too soon? And is it come into force too soon? And, you know, that's not a centric contact problem. The centric balance here is even, but early in the process, it's not. So we are going to co-develop our approach to care. We're going to consider the underlying conditions, and we do all of this by getting at the heart of the issues through a disruptive process of getting all of their scans done right at the beginning. It doesn't even take doctor time. I can get all my scans done. When I walk in and meet a patient for the first time, we have so much to connect on and so much to build a relationship.
Well, but the data that we are gathering is actionable data, because it doesn't matter that we just collect data for data's sake. If we can't take action on it that is in real time, that's what the T-scan helps with so much. And I know that we have, you know, within our business side, we take actionable data with, you know, snapshots of the practice software, so that we can get to the business, you know, what's working, what's not working, and how can we improve in areas of increasing patient care and also increasing team performance. Because I know that that is having a long-term profitable business, so it's a win-win. For the patient, because the patient, obviously in this picture, patient gets what they want and deserve, and then we've also provided a great service. But if we don't have actionable data and use it in an effective way, then you know, we don't deliver the excellence that you see.
Yeah, another way, you know, the way I think about that is that you know, when we go in and do a business assessment on a practice, if all I look at is what were your production and collections last year, I can't do anything about production and collections last year. But if I have data that allows me to see a trend that's going on, like are we retaining hygiene patients, or have we improved our case acceptance ratio, or have we improved our diagnostic ratio? What things are actionable? Who do we need to follow up with? If I have data that shows me trends, then I can be proactive or preventive in my approach to that business. This system of using disruptive diagnostics early with patients allows our patients to see trends in their mouth. So when they look at a trend of that their teeth are getting darker or shorter, or that they're collapsing, or that they can't swallow, or they can't breathe, or they're snoring more, or whatever it might be for that patient, when that patient has an opportunity to really use the data to see the trends that are going on, instead of just the pathology and the treatment plan. If all I can see is the pathology, you know, then my treatment plan is very difficult to accept. But if I can see that there's a trend going on here, with my T-scan data, now I can make a decision. Oh, you know what? This is trending in this direction. I might want to consider removing these 2 teeth and bone grafting and put some implants in, and then reset the whole foundation so that we can interrupt this trend. And that's really what Dee Dee and I like to do, both clinically and from a business standpoint, is think about trends and actionable data. And this is something that that we can't get any other way with except with T-scan. Dee Dee?
Well, and digital forms, you know, that's how we see it in real time and over time. You know, it's a tool that once, even after we've completed a case, we're still using a T-scan every year to make sure that we're not having any overload of forces and that we're not going to end up with a surprise like one of the first pictures you showed where the, you know, 2 teeth are broken off at the gum line. And so I don't ever want surprises like that for my patients. But more so, I don't want those kind of surprises for my doctor because, you know, that's a pretty disruptive, in a bad way, surprise. And so we want to be able to use the T-scan in a way that helps us monitor progress over time.
Cool. So as we revisit what we've talked about tonight, really our idea, our concept, the thing that we've been doing over the last 15 years that has made the biggest difference in patients accepting more comprehensive solutions that match their goals and their values comes by using our digital tools early in the relationship. And sometimes that gives us a huge window into how that patient would like to have a relationship with us. And we can disrupt this pattern of screening and open them up to a preferred future that might be right for them.
Yeah, another takeaway would be using their language so that they are understanding their condition and the underlying causes. And then definitely not treatment planning until the patient is clear about the trends and the issues. I want patients asking me, you know, well, what do we do about that? Well, how do we fix that? Like, what are my options? Versus me giving them all to them and they're like, oh, well, I've tried that, that doesn't work. So, you know, you can't give a solution until the patient is clear that there is a problem in the first place.
Right.
Then we can go into it together, plan an approach, plan a treatment, and then create the phenomenal result.
So I want to say thank you to all of you for joining us tonight. I know that we kind of ran a little long because Dee Dee and I just can't quit talking sometimes, and we are so passionate about using technology in a way that makes a huge difference to the care of our patients. And so we just want to say thank you. I want you to know that I have a problem with this slide, and that I'll fix it for you here in just a minute. But Dee Dee and I have a company called AmplifiedDynamics. We do coaching and consulting together. We are unique in that we like to combine business and clinical coaching. And so that if you would like to know more about us and find out something that's what's next from us, the first thing I'll say is that you can always visit our website at AmplifiedDynamics.com. Or better yet, for the first 25 of you who'd like to get a little snapshot of how things are going for you, if you would like to hear more about how we use T-scan, if you already have a T-scan and you want to review some scans, I will review 3 scans on any patient that you would like to share with me. We'll do it over Zoom on the computer. And
for the first 25 who contact us today, we'll get that special offer of that one-on-one with Dr. Montgomery. That is a big bonus going on right there. We also have another offer for those same people with having a free snapshot with from Dental Intel, which is a $400 value typically, and so we thank our partners at Dental Intel for giving us that connection. So if you guys want either of those special offers, you can text your contact information to me directly, and in the text you want to just type T-scan, and my cell number is 469-951-1995, and I am looking forward to connecting with you guys.
Awesome. And I know that T-Scan has a lot of things coming up also for you. So as I get my slides straightened out here, sorry about that. I want to just say a special thank you to T-Scan tonight. I haven't ever had a tool in my practice that was nearly as valuable in terms of helping patients move into a full mouth kind of conversation and really getting them the care that they deserve. I want to say thank you to TechScan for helping us out tonight and sharing this information with you. So I'll turn this back over to Carrie at TechScan, and I'll just say thank you and good night, everybody. Thank you so much for joining us.
Thanks for having us. Thanks for having us, Carrie.
Thank you so much, you guys. That was so helpful. I really appreciate you sharing a little bit more about your process and talk about actionable. I think you shared so many great communication strategies for people in talking to their patients already. So thank you. As always, for the audience, certainly you can learn more. We're always having courses, including webinars. You can learn more on our website at techscan.com. We do have a course in December, December 7th in Virginia. We'd love to have you on as well. And we will certainly share both of these opportunities in a follow-up email with you tomorrow, for sure. But I do know there are quite a few questions, and we definitely want to get to them because they're really excellent questions. Thank you for everyone who added that into the panel, so thank you. So the first question, guys, is there a typical practice that you help?
Oops.
I can't. Can you repeat the question, Carrie? I didn't get it.
I'm sorry. Yes. Can you hear me now?
Yes. Yes.
Okay, great. So the question is there a typical practice that you often help?
Well, for sure. People who want to grow and learn and be better than they were yesterday. And for doctors and team members who want to have a more profitable practice that is working smarter, not harder, that would be our ideal practice, because we love working with people who are the top performers, the best of the best. And typically those guys are the ones wanting to improve every aspect of their practice, and that would be our ideal practice. Mark, do you have anything on that?
Yeah, sure. I think that from my perspective as a dentist, I think that it's so easy for us to buy new tools or think that one new thing is going to make a huge difference. And the idea of integrating our systems into a practice, people who've bought things and they're just not being used effectively, or that they don't feel like they've really gotten their return on their investment, or that they've taken classes and they've learned techniques, but they just can't seem to get their patients to follow through with the kinds of dentistry that they love to do. I love helping people provide the very best care that they can provide to the patients who really want that care. And if we can influence that, whether it's through communication or through systems or through some sort of a disruptive transition, then we're in favor of that. We would love to help practices transform into the kinds of vision that the dentist really wants to have happen.
Excellent, great, thank you both. So the next question is, what is the easiest, most effective way to incorporate T-scan into my family practice daily?
Oh, great question. So I like using it as a treatment coordinator. So every new patient gets a T-scan. That's just a standard record that I would take. And then it would also be used in hygiene. Anyone who hasn't had digital photographs and T-scan, that would be the first place I would open that up in a practice, and start looking at how can we incorporate the data that we're actually getting into taking better care of our patients. So I know clinically we can use it on a daily basis. Anytime you see the crown, anytime you change the occlusion in any way, you can use it at the end of that to verify and dial in your occlusion, if you will. Mark?
Yeah, I agree with you. I think the first place is what we're talking about here is to just incorporate it into your new patient records and to make it a piece of communication that you do. The one thing that happened when I changed that was that patients would say this to me. They would say, "My other dentist didn't do this," and my response
Yes!
and my response was always, it wasn't quite what you just did, but my response was this. It was like, "They didn't? Huh." And then, because when I do that, then
Funny.
the patient just goes, "Oh, this is normal." And so I like to create that this is normal for us. But if you're going to create it as normal, then it should be normal. That's the best thing for me to say is just do it. I live in Oregon, so whether you like Nike or don't like Nike, we can't stop saying just do it. That's just kind of how we are.
Okay, great, thank you. Do you have any scripts to help clinicians feel more comfortable when starting out?
By scripts, do you mean like communication scripts?
I would imagine that is it. Yeah, the question.
I'll start first, and I will go back to that one little thing we said, and I would take all of the pathologies. I would make a list of all the pathologies that we look at in our practice that we like to deal with. So maybe it's wear, maybe it's crowding, maybe it's broken teeth or fractured teeth or abfractions or whatever it might be. And I would list all of those on a big board, and then I would do a staff meeting, and I would convert that language into an ing language of verbal skills. I'm pretty famous for saying that your teeth are like M&Ms. They got a hard shell on the outside, and you've got a lot of chocolate showing. And then I say, you know what M&Ms do? They melt in your mouth. And so I kind of go through this little thing, but it's when I create the idea that the enamel is melting off of your teeth, I don't have to go into if they're sucking on lemons or if they're bulimic or if they have acid reflux. I just go, the enamel is melting away. It's probably an acid problem combined with too much force. And so I would do a staff meeting on ing words, and then I would start using the terms that we use tonight, where the things that cause teeth to fall apart are acid, infection, and force. And I would just ask my hygienist when I walk in the room. The hygienist will say, "Well, this is going on." And I'll say, "Well, is that an acid infection or a force problem?" And the hygienist will go, "It's a force problem." And I'll say, "Well, then maybe we should scan the forces," and that's when we pull the T-scan out. So that's a little script that I would do with the hygienist, so that she has a way of telling me that it's a force problem, and then I say, "Well, let's scan the forces," or maybe she'll say,
or if your hygienist is on top of it, she'll say, "Here, let me pull up the T-scan that I already took for you, doctor, and you can see what we've already discussed. We see that the lower right area is, got 60% force on it, and we are wanting to get to the bottom of what the root cause is."
Thank you.
Yeah.
That's a great question.
Well, that's a great point. Yeah, and it's a great point to reinforce the value of having staff on the same page so they can reinforce the message, really.
Well, there's no way that this can be done without your team. That is your number one most valuable resource in implementing any system in your practice. Getting them all on the same page. And you asked about scripts too. Probably the best advice on scripts I could say is ask more questions, not tell the answer. So when patients ask you a question, come back and make sure that you are really clear on what they're asking and why they're asking it. My favorite line is, tell me more. Tell me more what you mean by budget and cost. And, is that something that is a big concern for you? Would payment plans be something that we could work out so that it would fit into your budget? But I would never come out with an answer without really being clear on what their question is and not making any assumption.
One of the most fun things that we do together is create these kinds of conversations and communication skills from a coaching perspective. So whether it's sitting down with the whole team, either over a Zoom meeting or live and in person, which is really fun. It doesn't have to be a big role-playing session, but we can help the team develop their communication skills in a way that allows them to speak the same language of the patient instead of the same language that we learned in dental school.
Mm-hmm. And taking it from initial phone call all the way through completing the case. It's like how can we ask the right questions all the way along the way so that we're delivering at the highest level for the patient and that we are loving them from a really deep place.
Great, thank you both. Okay, so the next question sort of continues this conversation around communication to the patient. And I think we both can probably have some input here. And the question is, do you have any marketing materials for social media or mailings to show patients how we use T-Scan and the services we provide?
I would say, what would you say, Carrie? You're the director of marketing for our tech scanner. You kidding me?
You throw that back to me, Dee Dee.
Yes, it's all on you, girl.
Certainly, yeah. I can answer that. TechScan does have some tools that you can share with your patients to talk about the T-scan and the value. And I think to Dr. Montgomery's and Dee Dee's point, sometimes I'm not even sure if it always has to be very built out tools as much as really nailing down how your staff and team communicate about the services you provide. Because, patients aren't necessarily always going to be on social media looking up your, dentists, right? So I think certainly TechScan can help, but I would say, certainly will supplement the conversation you'll have in the practice.
Well, a great way that you can introduce, if you are new to TechScan and you are wanting more of your patients or more new patients to be learning about it, I would say take a quick video of a new patient after you've used it with them and get a video on what their impression is of that, because it's very impressive on that initial appointment and they're like, wow, my old dentist never did this, and oh my gosh, now I can see things that we've never looked at before, and I feel so comfortable here. These guys are the best with this high-tech commitment. And so it builds trust, it builds connection, and it also builds your referral base. So.
Video is such a great tool, and I'm really glad you just mentioned that because, we have a pretty extensive YouTube channel at TechScan, and we get so many patients making inquiries to TechScan looking for dentists in their area that have T-Scan because they really connect to hearing the other patient stories, right? Because they're speaking their language. So I would absolutely second and say that, frankly, the videos are probably some of the most valuable tools. Mm-hmm. They're not geared to individual practices. They're not easy for someone to rebrand, but they're powerful real life stories of, you know, the life-changing treatments dentists are really delivering to some of these patients.
Yeah, it's a great third-party endorsement that we're not sitting around bragging about ourselves. Our patients are bragging about us, and that has a more believable story come across, because then patients can relate. You know, that sounds like me. That sounds like what I've been dealing with. I should go and see this doctor, because they really take it to the next level.
So could I just want to say one thing, well, maybe two things about that, and that is that we live in such an amazingly great time where people's testimonials and their ratings of us are so powerful, and it's so easy for us now to get that information out there, that you can do these short Facebook Lives. The studies are showing that videos less than 2 minutes are the most effective videos. So to take, and you think about that and you go, wow, 2 minutes. That's just asking the patient one question. Tell us a little bit about your experience of measuring the forces in your mouth today. And then just shut up and let them talk to the camera. You've got a Facebook Live. It's out there. You're off and running. And so it's just I think it's important for us not to narrate those videos. It's important to just stimulate them and let the patient go. And then use these incredible social media tools we have now, whether you want to do it through Instagram or Facebook, whatever you like with your media. But boy, it's such a powerful time for us to, as dentists, we finally get to show off. You know, it's like for years we've kind of like hidden under a rock, like, oh, we're a dentist, you know, we wouldn't want to talk about, you know, the fastest way to shut down a conversation on an airplane, tell them you're a dentist. You know, it's like, it's just so much more powerful now. And certainly we've been helped by all kinds of media that's out there in our favor, whether it's Invisalign or Clear Choice or the work that T-Scan does. But I think that we live in a powerful time, and it's just a matter of standing up for yourself and saying, this is who we are.
And the best time to do it is when a patient gives you a compliment.
Yeah.
Pull out the video camera at that moment, because that's the time to capture that enthusiasm and the emotion coming from your patient.
Hey, you just got a new video camera, but it's still in the iPhone box.
I'm going tonight, okay?
Yeah, it's a great point. Patients are the best dentists. So, you know, use your new phone and capture that for the future. Okay, guys, there's one last question that we just wanted to get to, and that is, do you take excursive scans on all your patients?
Yes.
Well, so
yes.
So I would say that, you know, when we're treating a patient and we're trying to sort out certain types of muscle function issues and pain issues and things like that, absolutely, we're taking excursive scans on all those patients. But to call it an excursive scan with a patient from a languaging standpoint, we don't do that. But on our initial scans, we usually take a multi-bite or a habitual bite scan, and then once we know that there are issues where we need to look deeper, then we always take the more full scans. It's like maybe we take a Panorex when we start, and then we realize that we've got airway issues and we need a cone beam CT. So yes, we use excursive scans all the time, and the timing of patients' chewing systems, whether it's non-working interferences or it's fast disclusion time or whatever it is that we're trying to accomplish, we're taking the scans that we need when we need to use them. On these initial disruptive scans, it's not quite as important for my treatment coordinator to be able to take excursive scans. But after you do it for a while, it's kind of like what you said, Dee Dee, about the hygienist. If the hygienist is already in and doing this all the time, I kind of don't tell the team. I don't tell the team which scans to take. They just take all the scans that I like. they take a habitual force, they take a MIP, they take a left lateral, right lateral, and a protrusive. They just take it every time we see the patient. But when you're first getting started, you don't have to take all those scans right at first, or if you want to do it on your new patient exam, you don't really need all of those scans for the patient to realize that they've got high towers of force on tooth number 3. It's just it's nice, but it's more part of your treatment process, I would say, than your screening process.
Well, and the other thing is anyone in your office can take a T-scan. My entire practice, from my front desk team all the way, my hygienists, my treatment coordinators, and my assistants, every single person in my office could take a T-scan, and they can do all 3, the habitual force and then the 2 excursives. It's like, once you have that sensor in their mouth, let's just do it and get it done. It doesn't take that much more time to take those 2 extra scans.
Right.
So.
Okay, excellent. Thank you both so much. I appreciate your time, and I really appreciate you extending this offer. We had a pretty large customer audience on the meeting tonight, and I think people will appreciate having this opportunity to connect with you more. As I mentioned earlier, we'll be sending an email to everyone with more details on courses as well as that offer. So look out for that tomorrow in your inbox. And thanks again to you both. We really appreciate your time tonight. It was a great message here.
Thank you so much for letting us.
Thanks for having us.
Of course.